I'm Tom Ryan. I'm with WPS Provider Outreach and Education. I'll be your presenter today. Today I'm joined by Leanne Foster. She's going to work with the chat and help me out throughout the process. We have a couple other colleagues on, depending on when they're looking for and what they're doing here. So we'll see how they go. They may help me answer questions a little bit later on in the presentation. Today we're here to talk about ambulance denials. Now this is information that we have pulled from our system to gather the denials. So it is actually data-driven education. We're going to look at data and we'll talk about when that data was pulled and what information you need to be aware of and all those different types of things. But of course, before we do that, we do have to talk a little bit about a couple of disclaimers. First, if you're recording this presentation, I do have to ask you to stop. We will record the presentation. Once the presentation is recorded, we will post it to YouTube as an encore. It'll be available to you. This is just because CMS does not allow us to have you record it for profit-making purposes, and because of that, we can't have you record. We don't really know how you're going to use it, so what we'll do is post that as an encore. A couple other things. This education material was current when I made it together. When I put it all together, I checked as much as I could this morning. Everything looks good. However, CMS does change and Medicare does change often, so please be aware that you should go to the CMS website for this information if you need to. I did take some questions in advance, and I will tell you that I prepared answers based on what you gave me in the question. However, for anyone who's heard an ambulance presentation before, you should be aware that one of the first things we'll say is, hey, minor details can change the answer. So the question and answer is based on what was given, and that's all I can give you. If you want more clarification or additional information, please use the chat. We will use the chat for all questions. All right. What's on our agenda today? Well, we want to help you get your claims processed on the first submission. We want to stop and look at these denials, talk about these denials, and the items that are affecting ambulance claims, because it's cheaper for you and cheaper for Medicare if we can get it done right away. So what are we going to talk about? Well, the top denials. These are the claims that are actually denied. We're going to talk about the top non-processable or not processed claims. These will be our return to provider or unprocessable. And then we're going to talk a little bit about some tips and resources and a variety of other things. So you'll see a variety of different things that you want to be aware of, and we want you to be aware of those. I will show you some different resources as we go, so it may not be a completely separate section, just so you're aware. All right. So what's the first thing you have to know? Well, it usually is helpful to understand where the data came from and what we're looking at and why we're looking at it. That's what I started with here. So what we did is we looked at claim lines. Now, claim lines come from two different systems. Remember, one system is the multi-carrier system. This processes all claims that were submitted on a 1500 claim form or an 837P electronic. Now, there's also the second system, and this is the Physical Intermediary Standard System. A few people will hear it say shared system, either way is fine. It's FIS. Now, FIS processes all UB04 paper claim forms and 837I electronic claims. So depending on how you bill, your data may look a little different, but it will also mean that other things may be different, such as how you fix or change something. Because with FIS, you can actually access the system and direct data entry and correct a claim. With MCS, you cannot. So please be aware of that. Again, one more thing to keep aware of, or one more thing, I guess, that was an interesting question, was they wanted to know what we actually look at. What do we see? What do we do? That type of thing. So basically what I did is put a screenshot. Now this is our claims denial dashboard. It's an analytics system. Very simply, I can use filters and a variety of other things, and I can say I only want part A, part B. So what I did here is just said, okay, I want denied claims. I want specialty 59. Now this is a part B or an MCS claim. And then it tells me how many claims I have, what I'm looking for, all those different things. It highlights different information that I need. Now in this case, because I was looking just for specialty 59, I did pull up this destination is not covered, just as an example. But I can look back and see what all the different claims are and how all the different pieces of information work together. Again, the more filters I set across the top, the different information does change. This is what we use. This is actually a federal system, and then we use it to bring it together for ourselves. So we thought that hopefully that answers your question on where the data comes from and what the data was used for during this class and what we're going to talk about today. All right. Couple of things. Let's talk about a denied claim first. I did have a question come in, and the basic question is, what is considered denied? Because I said denied versus not processed. Now, when we talk about denial, I'm going to use a couple of different terms for this. First, a denial is a claim that is one, not medically necessary denied, or two, you'll hear me use the term technical denial. Technical denial. Now, technical denial is something that we cannot reprocess, we will not look at again. You either have to fix it, fix something else, or we have to do something with it because it's not something Medicare can work with. A regular denial would be something like medical necessity, where you could support it in things and you could, by the things I should say, the medical documentation, whether that's your dispatch report, your ambulance run sheet, maybe it's getting some information from a hospital after the fact, hey, this is what we did, or this is where we picked them up at, and here's the discharge summary from that pickup. All of those types of things are what we're looking for. That's a medical necessity denial. So you'll hear technical, meaning nope, can't do anything with it, or you'll hear the term denial, meaning just a general denial or a medical necessity denial, and I'll explain more as we go through each one. But let's start with that first one. This is Medicare Advantage plan. Now, this is considered a technical denial because we can't do anything with it. You can't do anything with it. Here's what has to happen. What's causing this? The patient is enrolled in a Part C Advantage plan. It's a Medicare Advantage plan. This is Part C. Right now, it's denying for just for ambulance claims, not overall. 10,844 denies for this in the MCS system. Now, the FIS system doesn't have as many because it doesn't deny it the same way. It doesn't kick it back in the same manner. That's why it's not a denial. Remember, I talked about the two systems do different things. So here's what you have to know. First, verify that the patient's eligibility record is up to date. Don't resubmit a claim. Don't try it again. If that record is not current, we will not process this claim, period. Second, if it is not up to date, then you must update the record. Now, you being Contact the MA plan, you can get a denial from them. You can get them to update it, whatever the situation is, but we can't do anything until they update that record. The patient can also contact the Medicare Advantage plan. Unfortunately, without that update being complete, we as the Part AB processor are not able to do anything. Once everything is done, everything is done. In the MCS system, you must submit a new claim. Start over. The other claim doesn't even exist. It's just denied. So you're going to want to start over with that one. So it's going to be up to getting that record done first. And again, that's the patient's responsibility, but there are ways you can work with it, and it is the plan that has to fix it. One of the questions was, how could you as a provider, and what would you do to get a hold of the plan or to get a hold of the CMS regional office for help regarding this? That's why I put this resource on here. It's the MA Plan Directory. If you click on it, and you can do it right like I am here, it's going to say, oh, yep, okay. And it's going to open it up and it bring you right to the CMS website, and it is directly on the MA Plan Directory. This directly is up. This directory is updated. So here you can see this is the September 2024. And by opening this, you will be able to download the SAW, or you'll be able to unzip and then download the directory. And what this will do is give you every plan in the United States, plus the regional office, the plan name, the plan contact information, all of that to help you get through this process. Now remember, ultimately it's the patient's responsibility to update the MA plans. You as the provider, we as the claims processor simply have to wait. There isn't much we can do with it, right? So we want to make sure that you're aware of that. Okay, what's next? Our next one is actually non-covered services. Now, this one gets broken into MCS into two different categories, but MCS, remember that is 6,686, and it's actually broken by the type of provider first, which is an enrollment issue, and it means that when you enrolled, you did not enroll at the level of service you're providing. So for instance, you could be enrolled as a BLS ambulance service or a basic life support, but you're billing for an advanced life support level of service. We can't do that. You have to be at that level. Sometimes we get ground billing for air. Again, we can't have that either. So it just depends. We also have procedure code not covered. And again, it's just what's causing these non-covered denials. However, this does not separate them out. This says, hey, it's a non-covered denial, it's a non-covered denial. So what are we looking for when we look at these non-covered type of denials? One, you need to verify it's a medically necessary service, because if it's not medically necessary, then Medicare will not consider it. Then you have to verify, is your provider enrollment record up to date? So yep, the service looks good, but our record isn't up to date. We can't help you with that either. So you may have to go through the provider enrollment process. Now that does mean that you would use PCOS, the provider enrollment chain and ownership system, or the 855 application, depending on which one you are, and you would either use a B for private supplier, or you would use an A for a hospital-based supplier. And you have to get those records up to date. Without that, you're done. Now, if you do happen to have your record up to date and it still should be a non-covered service because it's not medically necessary, make sure that you're billing it with a GY for MCS. Make sure that you're billing with modifier GY, indicating it's not covered. You did expect the denial and it should be patient's responsibility. Now, a lot of times when we say rebill, that's what originally happened. And that's why we're getting this technical denial. All right, let's move on to the next one. Sorry about that. Not paid by Medicare. What's causing this denial? Now, this is one that is straight up not paid. This is a systems processing. It's a procedure code not paid by Medicare. Give you an example. Treat no transport. Medicare does not pay that. You still bill the treat no transport procedure code and you still bill a modifier GY, but it's not paid by Medicare. You cannot at this point override that type of a code. On the other hand, some people say, well, what else is not paid by Medicare? And one of those examples would be something like primary. You have a primary insurance that didn't pay it or that we don't have the information for, that means Medicare will not pay it. So these are types of not paid by Medicare. Now, primary insurance does have a variety of other aspects that'll come into it, but the general one is just using this one. And sometimes we use this to say we can't pay it because we can't even determine what the primary insurance information is. That's what not paid by Medicare would mean. Okay, let's move on. This is a lot of questions we got right here, so I do want to talk a little bit about this. Duplicate denials for ambulances are common. And we do have a variety of different types of duplicate denials. Now, this says MCS, and it's only because when I pulled the data, I only had the MCS duplicate denials. I didn't have the FIS-RTP denials for duplicate. Again, they're going to process a little differently. But here's what happens. We do have a variety of types. One, it's paid on another claim. Two, it's in processing. And three, it's an exact duplicate. So it's not paid on another claim, it's not in processing. But what's an exact duplicate then? Well, how about it went to deductible? Well, the patient still owes you the money, right? But Medicare's not going to make a payment. That's an exact duplicate. Or you submitted a claim, it denied for Medicare Advantage, nothing's been updated in the system, and you submitted the claim again. That's an exact duplicate. Nothing changed, nothing happened, nothing did that. We do have some questions on what duplicate actually means. Keep in mind, a duplicate denial for Medicare is not exactly perfectly the same modifier, for instance. So a duplicate denial could happen when a similar code is built. So what would be similar for ambulance? What if you build an ALS1 with a modifier HH and an ALS2 with a modifier RH on the same day? These could be duplicated. Why? Because what Medicare is going to do, or what CMS has said, is we need a fraud and abuse prevention duplicate. Edit. This one says they're close enough. They're both ground ambulance. They're both billed with an origin and destination modifier relatively similar. So you want to make sure that you're getting those billed correctly. Now, that does not mean we will not deny it as duplicate. Actually, the opposite is true. Some of these denials, again, will occur and you must do an appeal to fix them. So you first verify the claim status. Verify it really shouldn't be a duplicate. If that's the case, stop. Wait for the claim to process. Wait for it to say it's denied for whatever reason, and then you're going to file an appeal. When you file that appeal, it'll be a level 1 redetermination, and you must file with both of the Um, Run reports. What are we looking for? We're looking for the fact that it is not a duplicate. We're looking for the fact that they have separate time frames, even if they have the exact same origin and destination. Residence to hospital, hospital to hospital. What makes them different and unique? Okay, so we've got that part down. Then we also need you to incorporate on that run sheet or an explanation of why they should be both paid. Why were they considered separate? What makes them medically necessary separately and uniquely? So duplicate is not quite as simple as some people tend to think. Oh, let me just send it in and we're going to get this. Oh, okay. When we do the appeal, there's a lot of pieces of information you must incorporate. If you have more questions or you want more information, please put that back into chat. I already gave you a variety of pieces there, but I want to make sure that we get all of those answered because there were a variety of questions. The next one that we actually have for you is a hospice denial. Now, this is one where some people say, I'm not really sure why this is denying. First of all, once the patient elects hospice, anything related to the hospice must go to that hospice. That means if the transport is related to the hospice condition, it must go to the hospice. If it's not, it's your responsibility to tell us it's not. This includes the day of the transport to the hospice. Yes, we know they're not enrolled yet. Here's the thing. This is a workaround because the Medicare system does not contain a time. So it says, yep, today they enrolled. Okay, well, what time did they enroll at? Well, 2 p.m. What time was your transport at? Oh, it was actually at noon so that we could get them to the hospice and then they were enrolled at 2. Well, that means it would be excluded, and so that's where you'd want to build that modifier GW, letting us know that, hey, this actually occurred before, though it is related to the hospice diagnosis, they were not enrolled in hospice. Again, that is a workaround in our system. Also, ambulance transports unrelated to the hospice condition, you must make sure you have the appropriate modifier. So what do you have to do? Verify why the patient's in hospice. Once you get that, verify if they were admitted. We talked about that. If they are, if they're in hospice or it's a hospice related condition, you build a hospice. If not, you will build a modifier GW to indicate separate payment for this one on the MCS system. Okay. So it's very, very complex and you have to make sure you do it correctly. It is your responsibility to bill it correctly. We have a lot of people that don't put the modifier GW. Someone did ask me if there is a place on our system that you can look for this, and yes, there is. What you're looking for is a hospice and which hospice they are currently enrolled in. That is in the secure section or the portal of our system. And so we'll talk about that in just a few moments. Actually, let's talk about it right now. So what we'll do is we'll come out to WPS GHA. Now this is just our website, it's WPSGHA.com. You can see right here on the right side, kind of third item down, is this big login section. This is where the information is located. Here's what can't happen. I can't access this. I don't have a need to. So we're going to use the portal user manual. I'm just going to show it to you. Doesn't matter if you pick A, B, all of the portal itself will be the same. So each one of these doesn't really matter. Accept the licensure agreement and then scroll down and talk about how to get an account and all of that. If you don't like a fast scroll, please look away. I'm going to scroll really fast. When you get to the transactions section, which is on the bottom, you want to do an eligibility check. Inside the eligibility check, it'll explain all of the information you need as you scroll through. What it will do is actually show you the different pieces of information. The last item is hospice. Now, if it's gray, like on the screen right now, that means we don't have any hospice information. If it's blue, like on the ones above, there is. So what would you find if you were to look for hospice? And again, I'm going to scroll down to this section, so bear with me here. The thing that is important is it will give you the hospice's legal information. So what's their NPI? When was the election information? When was the revocation, if applicable? All of those different things. It's going to give you this information to help you out. Hopefully that kind of helps answer that question. If not, throw some more information into the chat and I will get you some more information on that. The next one is very specific to ambulance. And this is a denial that is being caused because the origin and destination, the modifier is not valid. Something isn't working with it. And I'm going to explain that in just a few moments. So the modifier isn't recognized by Medicare. So what do we do to fix this? Well, first, let's make sure we're using the right modifiers. I gave you a link here that says these are the ones Medicare recognizes. Now I'm going to go ahead and open this. I want to show you one thing that you need to be aware of when you look at these. There are some modifiers that are not universal. They are not origin and destination. Okay. So what we do is we hit F and we're just going to say origin. We're going to use that as my example. Okay. Great, great. And you're just going to scroll through. What it will do is give me a list of origin and destination modifiers. And here is our list. What I'm talking about is this one right here, which is an X. This is a destination only code. So if this is in the origin spot, won't pay. The physician's office is an origin code, but not a destination code. Medicare doesn't cover a physician's office as a destination unless it's an emergency stop, in which case we give you a special one down here. So you have to make sure you have this. For the facility billers, now that's the ones that bill in the UB04 or the 837I, that's this institutional claim stuff up here. We also sometimes are missing these two modifiers, which tell us how the ambulance company is owned. So you have to know that. Okay. So there's just a variety of different modifiers, and you want to make sure you're using a specific modifier and you make sure it's the correct one. Another one that we did get a question on, I do want to address right away, is an E, which is a residential, domiciliary, or custodial care, versus an N, which is a skilled nursing facility. So they're both types of facilities. They both could be nursing facilities, actually, but one is when the patient is in skilled care, and one is when the patient is not. Then it's considered residential or domiciliary. So make sure you're using the correct one. Once Medicare is no longer paying for the skilled care, then you want to use an E. So again, if you have more questions about the modifiers in particular, let's take a minute to talk about those, but put them in chat and I'll get back to them in just a little while. Okay, timely filing. Well, this one is interesting because you get 12 months from the date of service. That's it, 12 months, all you got. And if you file outside that, your claim will deny. So when you look at it, you have to make sure you're doing this right away. Also, inside this one, there's before coverage and after coverage, patient eligibility. We'll talk a little bit more about that. But here's what you have to do for timely filing. Please make sure you're billing the correct entity. This is the number one cause. One, are you billing the primary and then us, or are you billing us within that 1 year when they haven't made a decision? Did you catch that? You can actually bill for something expecting it to deny to Medicare because we can work with it if the primary insurance has not made their decision. You still have to bill it within 1 year, 1 year from the date of service. Now, there are times when timely filing occurs and you're like, except I just found out the patient was eligible because Medicare retroacted their eligibility due to a disability situation or a variety of other situations. That was the exact question. First, keep in mind Medicare does not retroactive eligibility. That is done by the Social Security Administration. The Social Security Administration does all the eligibility determinations. So the Social Security Administration does do that. We ask that you use the correct term because the letter you're looking for will come from the Social Security Administration. So that's just key to make sure you understand. Also, it's important to let you know that the patient let you know on this date because that's part of retroactive eligibility. Now, when you do that, do not file an appeal. If you file an appeal, we will dismiss it. You must write into our claims manager. When you write into the claims manager, you're going to incorporate the letter explaining that information, the letter from the Social Security Administration, all of those different things. So you want to make sure that you're doing a variety of things with that. You also need to incorporate the pink, red, whatever you want to call it, but you want to incorporate the UB04 or the 1500 claim form. These claims must be processed manually. And in order to do that, we must have a claim form. So we can even say, yep, we would have granted you a timely filing exception, except we got no claim. That will also happen. So Yes, you need to file it, let it deny, make sure that you get the denial, and then you're going to file for the exception. Again, an exception filing is not an appeal. So we do know that there's a variety of different pieces that fall into this, and you want to make sure you have what you need. Now, the reason that this talks about before and after coverage is because with timely filing, you also have to check to make sure the patient was covered at the time of service. And so that's where the retroactive information comes in, and that's why those two are there, but we'll talk more about those in actual patient eligibility. All right. If you do not file a claim timely, and remember there's very limited circumstances, then what will happen is you must write off the charge. You can bill the patient for whatever they would have been liable for, but you are responsible for determining what that liability would have been. Okay, lots of things go into that. Next one is a denial saying, hey, we don't have the primary payer information. Give us the primary payer information. So what we want you to do is to go in and say, okay, this is the primary payer information. Sometimes this denial is correct, and I just described that. Remember I said you got to file it timely even if they haven't paid it timely within that 1 year time frame. So we expect the denial. The goal is then to work it. So we know some of these are correct. We thought we would put it in because if you don't have it on there, obviously it's going to make sure that the claim will deny until we get it, and then we can work it later. So that's really why we put those two together right side by side there. All right, patient eligibility denials. First, please make sure that when you check for patient eligibility, you're checking to make sure your date of service is not before or after eligibility. Now, in the FIS one, it breaks it out nicely for after date of death, which would be after eligibility. They're incarcerated. They're not eligible because the state or the governing body that they're incarcerated with must pay for that. Also, not a US citizen. So you can see FIS has a little bit of a different eligibility denial than MCS does. Let's talk a little bit about before and after effective dates. A patient gets their Medicare card approximately 60 to 90 days before their effective date begins. That means they can have it in advance so that you as a provider are ready to bill. It is sent out by their local Social Security office. That's why it is not a set number of days. Each office does it a little bit differently. So you must verify that. Someone asked, what do you mean by after eligibility? And here's the thing, or after coverage. If a patient stops paying their premium, they will lose coverage for Part B. They'll also lose Part A coverage if they happen to be a premium. But more commonly, it's someone who had end-stage renal disease with a successful transplant. Their coverage ends 1 year after they stop dialysis or 2 years after the transplant. It just depends. Also, someone who is disabled who is no longer deemed disabled. So for whatever reason, they've gone through whatever the process is, and Medicare now, or I'm sorry, and the Social Security Administration does not deem them disabled any longer, then they will lose eligibility. So just because a patient had Medicare at one time does not mean they do today. Keep in mind, 65 and older still doesn't mean that. And that's where we get one of the common misconceptions. A patient must pay their premiums. If they don't pay their premiums, they're still not going to be eligible. Some patients will choose to stop paying that premium due to the cost of it or for whatever their purpose is. So please make sure you are verifying they are still eligible. The next one, a couple people asked us about in particular, so I thought I would put it in, and this one is bundling. And this is when the data service incorporates into an inpatient claim of some sort. So for MCS, it's usually hospital or skilled nursing facility claims. Means the patient is inpatient somewhere. Is there a date you can look out and find out? Not exactly. The Part A eligibility systems that you guys can access through the portal and the Part B eligibility systems, which you can access through the portal, will have information to say they were in a certain claim or they have a certain date and when this started and how many days they have left, all of that. So yes, these are denials, and yes, we know they're there. Couple of things about skilled nursing facility. This one is a little bit more complex if they happen to be in that, because there's a whole set of caveats saying it's outside their scope of practice, which means by procedure code at the destination, the ambulance run would also be outside the scope of practice. So it gets super complex. Question came up on where they can locate these covered or non-covered SNF procedure codes? And the answer is the CMS website. Let me take a moment and I'll show you that one. So to come back out to the CMS website, go to Medicare, coding and billing, and then we go to skilled nursing facility consolidated billing. These are your code lists. Lots of stuff going on there. You can take a look at any of those that you want. They will get you the pieces of information you need. If you want to learn how to use them, because I don't have time to go into that today, going to recommend that you come out here and you go to YouTube, just youtube.com. Once you enter YouTube, search for the WPS GHA channel. So WPS GHA channel. This channel will open, hopefully. And once you open the channel, which is right here at the top, you can go through and go to our playlists. Inside the playlist, we have a whole set of information. One of these playlists is ambulance. And when we look through here, if you look for these encores, which is what I'm looking for, there's one called Skilled Nursing Facility Consolidated Billing right here. This will teach you this information. Okay, so yep, we know we got this. We know it's ambulance. We want to make sure we're getting what we need. We can read through or we can look through all of these different items. Does that make sense to everyone? Hopefully it does. So if you want to learn how to read those charts and do all of that, rather than me sitting with you, I wanted to show you the resource. Okay, show you the resource. All right, last to now before we take some questions. Supplier eligibility. This one is quite literally that for whatever reason, the ambulance supplier's eligibility or enrollment record is not current. So you must update that. You can do that again via the provider enrollment chain and ownership system right here. Also update to make sure you didn't miss a revalidation date. This will shut your eligibility down. So please make sure you're doing that right away. So we want to make sure you have all of those pieces of information. Again, you do need to first update your eligibility record, which means update your provider enrollment record. And once that record is updated, then you will be expected to resubmit a claim as long as it's within the time frame. All right, that brings us to our next slide, which is simply questions. What I'm going to do is just give a couple questions that were pre-submitted, and then we'll move on to the questions that are in the chat, and we'll go back and forth a little bit. So hopefully you've gotten one of the first pre-submitted questions is what could cause an ambulance claim to deny? And there's a lot of different reasons. We went through a few of them, but hopefully you're aware of that. The next one is how do you correct these? I tried to address this as quickly as possible. When you have a denial, each one is different and unique. Some of them are not correctable. They're simply not part of the Medicare program. For other denials, you will need to do an appeal. We gave you that with the duplicate denial. You need to show us this is not a duplicate service. It is a separately identifiable transport. Other ones, you could do something like a clerical error reopening. So it denied, but it's denying for something that you still need to add. So it just depends. There's a variety of different ways, and each denial will be unique and different. And again, what causes these ambulance denials? Well, there's a lot of different reasons that they deny. So we don't really have an exact answer for that in that manner. Hopefully that does help you. One more to address. What are ambulance requirements? Well, if you don't know the requirements, you're likely to get a denial. Let me also then indicate to you, I want you to go back to that ambulance YouTube playlist and I want you to find the courses that affect ambulance. We have a huge number of courses out there that will walk you through all of the ambulance requirements from enrollment to claim submission to the way a claim processes. All of it is available for you. One other resource when you're looking at ambulance requirements is the CMS website. Now leave this for a second and you're going to come to regulations and guidance. You're going to go to manuals, literally the word manuals, internet only manuals. Inside here, there are two areas I really want you to focus on. The Medicare Benefit Policy Manual, in particular, Chapter 10, which is all about ambulance services. Okay, so that's one area. The other one that you really will need to focus on is 100-04, the Medicare Claims Processing Manual. In this case, it's Chapter 15, which is all about how a claim processes. If you get familiar with those, you will definitely become familiar with the different um, ambulance requirements and all the pieces of information that are needed. Those two chapters will link you to various sections of things like the Social Security Act as well. So really great resources to start with. One more thing on the CMS website, if you're not familiar with it, if you go to Medicare and we scroll down here, actually let's do it this way instead, just to give you an idea. If I just want to search the word ambulance, I can say I want a service center as well. You can locate it the other way, but by doing that, it'll bring up a variety of different things. One of them is the ambulance service center. So if you just type ambulance, ambulance services, or ambulance center, it will bring this up. What's great about this is CMS takes all those different resources and links them directly from this service center, so you don't have to go hunting around the website for it. So I'm going to give you that as another resource. Two, day-to-day operating instructions, which are called the Internet-only manual, guidance, reference manuals, plus this area should get you through hopefully what you need. With that, Leanne, do we have any questions?
Tom, we do have a couple of questions in the chat. The first one is you were talking about the hospice time. The question is, how do we find that?
So there is no system that's going to directly give you the hospice time, and that's what I was talking about. Our system doesn't do the time. What it does is gives you a date that hospice was enrolled on. So basically, if you're taking them from a hospital or somewhere to the hospice, just automatically bill it with a GW because you know they're not enrolled. They can't be enrolled. How do I know that? Those day-to-day operating instructions, there's a whole section on hospice. It says you can't be enrolled in a hospice until you're at the destination and complete all the enrollment paperwork. Well, that means if you're transporting them to the hospice, guess what? They're not enrolled in the hospice. So hopefully that helps answer that question. So it's automatically on a transport to hospice where you know they're leaving like a hospital or another destination. Don't have to worry directly about the time. Just know the system doesn't have it incorporated. That's why we can't display it for you. Next question.
The next question is about the GY. Their question is, um, let me start over, sorry. We have a question about the GY to make it deny, but why does that not work on Medicare HMOs?
Okay. So the GY modifier is something set for CMS for traditional fee-for-service Medicare, in other words, Medicare A and B. They are not requiring it for HMOs. So, because they don't require it for an HMO or a Part C Medicare Advantage plan, what you must do is contact each one of those individually to find out how they want you to bill those. So, there's a variety of different factors that play in with that one, but the GY is specifically set for Medicare traditional fee for service. Now, if a Advantage plan takes it, that's their decision. It's not something we can really look at individually. Next question.
Next question is how to handle verification of death on a date that is after the date on the death certificate. An example, date of service is 9/10, but the medical examiner determined the date of death was 9/5. This rejects because care shows date of service after date of death.
Okay, so depending on the situation, I would answer this in a couple of ways. One, what was the service that was done on 9/10? If it was a transport that was done on 9/10 and the data occurred on 9/5, why did you transport them? Should this have been billed with the appropriate QL modifier? Maybe there may not have been I'm asking that question because I don't know why you were dispatched, I guess. So with ambulance one, it's a little bit different. So if you could give me a little more information, I might be able to help you out more. But otherwise, what I would say is if it was clear that they were dead when you arrived, and even though the service occurred, you do need to make sure you bill with the QL or quit living. Some people like to call it modifier. In other words, you dispatched, expected to find a living person, but you didn't. That would be a QL. So that would be when you want to make sure it's on there to indicate to us that it occurred in that manner, but you do not get mileage for that. You don't get mileage on that one. Uh, Again, if you have more on that, let me know. Put it back in chat. Leanne, next question.
And this is the last one that we have in the chat. I'm combining two comments that were made. We've seen hospice dates change quite often. This causes denials. Also, hospice are denying once past timely filing, so the hospice held on to the bill too long. I think the question is how to handle that.
So first of all, We don't have any control over any of that information, so the hospice has to make sure that they get it into the system. Now, you could have us work with something that you actually have in the system. You can call and work with us or talk to us about it. You can say, hey, we did file this timely, hospice didn't do their job. Here's the proof of that. We can work with that. We can look at it. You can always take it to CMS and they can give different instructions if they need to, and the regional office can help you with that. But we don't really have any of that type of information. So, anything
Oh,
else?
all right. Nope, Tom, there are no other unanswered questions in the chat.
All right, let's move on. The next set is just not processed errors. Now, this is different than a denied error because remember, a not processed error means we didn't adjudicate the claim and we can't work with it. So this is where we wind up with some different information. So in FIS, we call this a return to provider. In MCS, we call this unprocessable. Now, in FIS, you enter the system and fix it. In MCS, you must submit a new claim as if the other one didn't even exist. These are the types of errors that we're talking about here, and that's why you're going to see something you say, "Well, that looked like a duplicate," or "Hey, didn't we just talk about that one up in the denied services?" Two different types of ways to fix. Okay, so not covered charges. Claim is not processed as provider submitted a non-covered line item. Well, you told us it wasn't covered. Why would we process it? Well, in FIS, we won't. We'll simply say, nope, it's non-covered. So remember I talked about that GY modifier that says this isn't covered? That's okay. This is what's going to happen. All right. Second, information needed. Something's missing. Now, again, this is a very big one. And for MCS, we don't have a specific information. On the other hand, what they do say is this is our reason code, our financial code. You need to read your remarks code to get more information. So that's what you need to do. Get a remit notice. That may mean you need to go out to the portal, download the remit notice, and read the remarks code. Tell us what's going on and what's missing. Once you determine what's missing, then you have to submit a new claim with that missing information. The other thing you could do is contact customer service and say, I know it's denied. I see that it's denied. Only I can't figure out what's missing. I can't even understand what you're telling me is missing. So I don't know how to fix this. This is different than saying, why is it denied? Okay, did you guys get all that? You got to give them more than that. That's what you want to do with that one. So again, the information is needed. We just don't know what information is needed. And because this is such a generic high level code, you do have to move down to the actual other code on the claim, which is the remarks code. Next one, we will not pay it, and it's railroad Medicare. Now again, we won't pay it. Palmetto GBA, who is the railroad claims processor, will. So this one you must submit to them and you must just go ahead and send it to them. Now, there are times when we will forward, and you'll see it says forwarded 227 versus not forwarded 914. And that depends on the information that we have in the system, what's going on with it. There's a variety of factors that indicate whether or not we'll forward it to them. What you're looking for is on their Medicare card where it says Railroad Retirement Board. You can see it in the red banner on the bottom. That's what you're looking for. If you don't see that, then it's traditional, then we would process it. Couple things to keep in mind when we talk about railroad Medicare. There is no way in the system to look at it and say, yep, they have railroad versus traditional or non-railroad Part A and B because it is still part of Part A and B. It's just who issued their Medicare card. That's it. That's all it is. So you want to make sure you have that information. Okay. Authorization number. Now, for those of you that are not familiar with this, the unique tracking number or the UTN comes from the prior authorization program that is for only for the scheduled routine scheduled non-emergent ambulance transport, RASNet. And you can look up a lot of information on RASNet, but really what we're looking for is something that is scheduled, something that has to be done in advance. And you must have this number. Now, could the number not be valid for the data service? Well, yes, that's what's happening here. The number you're giving us isn't valid for the data service. Do you know you don't even have to give us a number? It's not required. It's an option, definitely an option. We'll definitely help you if you want to do it. But if you don't want to do it, or if you don't have one for that, don't use an old number on a current claim. When it's authorized for starting at a certain date, don't put it on before that date. You have some transports before, up to 3 transports before we'll even begin to do the development for it. If you don't have the UTN on the claim at all, we will still develop for this. This is not something that we're just going to ignore, except if you put the wrong number on there, then we won't even process it. The claim won't go anywhere. So please make sure you're aware of that information. Keep in mind this type of transport that needs a UTN, which again, routine scheduled non-emergent transport, is only for Part B claims. So it's only an MCS. Now, a Part B claim again is a 1500 or an 837I claim. Patient's Medicare number. Here's where we wind up with not that the patient isn't eligible due to before or after or anything like that. It's just straight out something doesn't match and I can't match this patient. I can't make it work. So for instance, their name doesn't match the system. Their Medicare number isn't in the system. Something isn't working. So what you have to do is verify what we have in our Medicare system. What is the name the patient has in the Medicare system? So for instance, would I be Thomas Ryan? Would I be Tom Ryan? Would I be Tom without the H? All of that matters. In my case, it would be Tom, Thom, Ryan, Ryan. Not Thomas, not Tom, Tom. And so that can all cause those names to match. Also, if for some reason the Medicare number happens to be wrong, we're not going to process that. So you want to make sure all of it matches. Check the system to verify that before you file and then file again. Here we go with these modifiers again. So sometimes we don't even know what the origin and destination modifier is, or it's just not there. In that case, we can't do anything with it. One of my most interesting ones for this was someone building an ambulance claim with a modifier 25, which is an evaluation and management code or a physician code modifier. And I was like, yeah, that's just never going to get through. It's probably just a typo, nothing major, but you want to make sure you're doing that. That's the modifier and procedure code are inconsistent. Missing, or I'm sorry, also invalid modifiers. If a modifier is not valid for that data service, so CMS implements a new modifier or something like that, it would be on this list. We don't have any of those right now. So fix the origin and destination modifier. Again, I gave you an example of where to locate those. They were earlier in the program. Check the modifier and procedure codes are a valid match. I gave you another example of that. And then please make sure that Medicare does actually recognize the modifier you're using it for in that way. And we gave you an example of that with the P for physician's office. So all of those can cause other types of issues as well. Hospital bundling. So this is where they're in a Part A state. We talked a little bit about this, but in particular, this one is hospital bundling, and the ambulance transport is not at the beginning or end of the transport. It's in the middle of it, so in the middle of a stay, and that's what causes this one to be unprocessable versus some of the other bundling ones, which do affect a little differently. So first of all, you do have to verify the hospital and then verify if the discharge was billed. That's one of the key things with this one, is the discharge billed because hospitals bill on 30-day increments. Their first claim must process before their next 30 days, and that claim must process before another 30 days. So let's say the patient's in for 90 days. Your ambulance transport is to an MRI, and it's on day 51. That would be part of the MRI procedure, not separately billable, but also not a separate ambulance charge on the hospital claim. And there's a lot of confusion over that. It is correctly bundled. But let's say your transport occurred on day 94. Wait, but there was only 90 days. Okay, then we have to go back to the hospital and be like, hey, did you bill that discharge yet? Because they don't bill on the same cycle. They don't bill as a service occurred. They have to wait until the end of the month. So some of them will say, no, we haven't billed that, right? That full month hasn't passed for us to do our billing cycle. So this one gets a little trickier and a little bit different, and sometimes does mean you need to talk to the hospital before you bill it. But once everything seems to be good, then you're going to want to bill it for payment. MSP, again, this is an incomplete information bundle or an unable to obtain primary. In other words, we don't know what you're doing with it. And remember I said, how we denied some in the MCS system. FIS doesn't deny. FIS automatically just says, hey, we're going to return this, fix whatever you got to fix, whatever that situation is, it's different. Now, MCS does break it out and say, hey, we don't have the information versus we have incomplete information or partial, or we don't even know what you're looking for. That's a different type of denial, or that's a different type of unprocessable. So FIS doesn't even process the claim. MCS will process depending on what's there or make some unprocessable. But again, check all the fields, make sure all the information is up to date, current, and ready, and then resubmit the claim. Point of pickup. Now, this is definitely an MCS one, and it's very few. You can only see it's only 42. But what happens is if we don't have the point of pickup zip code on the claim in the correct box, we can't price it. We simply cannot price it. If we can't price the claim, then it doesn't do anything for us and we can't process it. Because that point of pickup zip code is part of the ambulance fee schedule, so you want to make sure it's on the UBO for it, you're going to have an AO. It's going to be in the appropriate box on the 1500, and you want to make sure all of those are done correctly. If not, we will not price your claim, therefore we cannot pay it, which is why it actually either will return or become unprocessable. United Mine Workers of America, this is a separate plan that pays for some Medicare stuff. And so if their patient is eligible, you want to make sure you're aware of it. For MCS, this is only 33 denials. It's very specific to Michigan and other types of things. I do recommend there's a resource. If you're getting this one and you're not familiar with it, take a minute and read that resource. It'll help you get through the process. But again, it's not a lot, but I did want to make people aware of it because I did have a question that came in very specifically on the United Mine Workers, and they said, hey, we only get these in this one state and we process for 40. Well, I understand you process for 40. Unfortunately, it's just not across the board. It is basically an MA plan in one state, though it's not directly under MA. It's just a little bit of a different type of plan there. Last, or coming up next, is diagnosis codes. So someone asked, do you need a diagnosis code on the claim? And my answer to you starts off with this. If you're going to put a diagnosis code on the claim, it does need to be valid, which means it needs to be a current ICD-10 code. If you're going to put an ICD code on the claim, it must be there for an electronic submission, period, and a UB04 submission. However, a paper claim form 1500 does not require it. So it's the actual requirements for billing those other types of claims that do require it, especially electronically. Now you can see here it's just 12 denials and it's because this is not valid. When we did a little digging into this one, it's that they used an old code, no longer valid. It's not in the current correct format. So please make sure you're using that format. Lacks information. This is just a really generic return, and we really want to know what are we lacking. You do have to go back and again check this one out, but check those remarks codes. It's so general that I really don't have any information to give you. And of those 15, every single one had a different reason that it lacked. So it wasn't like a good one, but I thought I would still include it. The next one I put in very specifically because it is a fifth system denial. I understand there were only two denials for it, but I did get a question on why this happens. And the actual answer comes from the Medicare Claims Processing Manual, and it says that when certain lab services are billed, regardless of what else is billed by that provider, it automatically bundles them. So you have to make sure that the lab and all of that is built, but this is the information you need to understand that denial. So if you were the one that asked about this, please go ahead and stop, read the information, hopefully get a better understanding. Do it within the next 7 days and then email me a question if you still have a question. Again, I don't want to spend a lot of time on it because not a lot of you guys had questions on it. So with that said, let's see if we have any questions. Leanne?
We do have a question in the chat. Um, we have seen Medicare paper C plan recoup 2 years past payment stating Medicare was responsible. So we file the claim, get the timely filing denial, file the appeal, and get another denial. We include recoup notice along with the original. I think this is specific to Part C.
Yeah, so when Part C happens and does that, first of all, it's the reason that that isn't considered denial of that sort. You can try to file it. Please don't file an appeal. If you're getting that denied through an appeal, then that is appropriate. It's not an appeal. If you're filing the waiver and you're getting that denied, it's denied because CMS would state that it's your responsibility to make sure it got filed properly. I'm not sure how that works. Don't know that. If you have questions on that, you do have to contact the regional office. It's not an override situation we can do. So you have to contact the regional office and work with them to see what's going on with it. Also, you can contact the regional office for the plan. That was in that plan directory that I showed you. Next.
Next, we have a question. It's claims with D auto denied, but patient is paraplegic, cannot sit. Transport meets medical necessity. Oh, I'm sorry. I am on the second half of that question. Let me start over. For a provider-based apartment that is off campus, located more than 250 yards from the main campus, what modifiers to be used for the transport, D or H. That's where they're saying the claims will auto deny with the D, but the patient is paraplegic and cannot sit. Transport meets medical necessity.
So if it's an off-campus department of a hospital and it is certified as part of the hospital, it is an H. Doesn't matter that it's an off-campus, it's still part of the hospital. So hopefully that answers that question. Anything else?
There are no unanswered questions in the chat.
All right, so again, as I promised you guys, I did build a section in for resources, but I've already showed these to you. So I want to make sure you're aware that, yep, it's here. I did try to get you some different help, but as I went through them, I thought it was probably more relevant to talk about these. This is the slide that I just brought up is the ambulance help on our website. We do have a documentation article that was written with our clinician support. So Mary Sue Gardner is one of our clinicians, myself, and our medical review team put this together to make sure you have what you need. Ambulatory, statutory, and billing requirements, ambulance suppliers, timely filing. These are all articles that will help you along with those playlists. They're just different resources we have to help you. And we've seen a couple of those as well. Provider enrollment chain of ownership system. You heard me mention it. You heard me say you might need to complete one of the forms. These are just the forms and actual links to Pico. So I'm not going to show those to you, but I just wanted you to have them anyway. With that said, I do want to hit just a couple more questions and then we'll see if we have anything more in particular. So, question number one that we have, best way to appeal a clinical denial. Anything clinical editing is going to be the same appeals process, which means you must file a level one, then you must prove it with the AMT documentation, all of that type of thing. There's no best way or different way to do it. I do recommend you use the portal. For me, that is the best way in terms of manually filing it versus electronically filing it. When there are two line items for ambulance, if we cannot bill for mileage, what do we do? We don't know that you can't bill for mileage. Medicare systems don't require a mileage on a claim. Ambulance claims can actually be billed for it. This may be a system edit within your system. So you want to make sure you're checking that, and that's maybe something you need to work with your system on. But Medicare will accept a claim with only one. And we do that because of the QL situation that we talked about earlier. How to properly bill for a treat no transport. Again, you're going to bill it as a treat no transport. I believe that's the A0998. Don't quote me on that, but I think that's the right code. And you're going to put a GUI on it. Once you put the GUI on it, we aren't looking for anything more other than just to get it through. If you do need to bill a mileage code, you can bill an A0425 for ground if you need to. And then you're going to put a GUI on that as well, making that payable to the patient as well, but you're only going to bill, a fractional of a mile, 1/10 of a mile with the minimum charge on that. So we went through the top reasons for denials. Uh, what else is that? Let's see. All right, somebody asked again a little bit more on, and I'm guessing this is data death information, which we already talked about with the GY. Now, there are times when they get there and they say, wait a minute, how did you not know, or this is not payable? You're going to have to build the estate. That does also happen. And that's when it's so long after the date of death that even though the transport is you're expecting a living person, it was very obvious they were dead and someone should have called it in as a dead person. And a lot of times those are ones where even you don't transport them in terms of you call a coroner and someone comes and gets them. That's not payable. It's usually not going to be a situation where it's payable because it's so long after the death that it was obvious they were dead. So there isn't much we can do. What we can tell you is if you happen to have a situation like that and you disagree with it, you can always go to the appeals process. If that doesn't work, then you'll need to go to the regional office to see what they can do for you. But in terms of that, we are unable to override that here at WPS. All right. Don't think I have anything more, but Leanne, do we have any more questions? Okay, not hearing anything. Here's what I'd like to do. First, just remind you guys, please take the survey. I'm going to have Leanne put a chat for that survey. Put a chat. I'm sorry, put a link in the chat. This will just help us get it. Also, I'm going to go ahead and when I close this presentation, you get a pop-up box. Take the survey. Tell me what I did good. Tell me what I did bad. What you'd like to see regarding future education, whether ambulance or not. We don't really care. Just tell me the good, the bad, and the ugly. What I did good. What I did bad. Did you like my PowerPoint? Was it helpful? Any of that type of information is awesome on the survey. I'm going to give you 7 days to send me an email. How do you do that? WPS, period GHA, period education at WPSIC.com. Help, ambulance denials. I'm sorry, help, no, take that out. Put subject, ambulance denials. Sending me the next 7 days, I'll get you those answered. I think I got every question in the chat answered. If not, I will respond to those as well. And then the certificate, a couple of you asked about that. The certificate will come out in an email. It's actually incorporated into the follow-up email you're about to receive. When you get it, it's on the bottom. Please make sure you check that email. It's going to be there for you. So you don't have to ask us for a certificate if you don't need it. If you happen to have called in, you do need to email where I just gave you and ask for a certificate for this course. Again, subject line, ambulance denials. I need a certificate, dot, dot, dot. But then I also need you to give me a phone number with area code that you dialed in from. Otherwise, I cannot issue you a certificate. No phone number, no certificate. So again, that's all I have for you. Thanks for attending. Take this survey, give me your feedback, and we hope to see you again at future education. So again, from myself, Leanne, and everyone at WPS, we want to thank you for your time today and wish you a great day. You may now disconnect.